let's jump into the sessions, though. Our first one is going to be a fireside chat. I want to bring up Kavitha Gnanasambandan, our CEO and co-founder of Blooming Health, and Chief Michelle Alletto. Thank you.
Awesome. You guys can hear me. Good morning, Dallas. How's everyone doing? Awesome. Thank you so much for taking the time to be here. I'm excited for this fireside chat with Chief Michelle Alletto. We like calling you Chief Alletto, but I'm going to call you Michelle. I know that's your preference. So I'm Kavitha Gnanasambandan, co-founder and Chief Commercial Officer at Blooming Health. The topic today that we're going to discuss with Michelle is very personal to me, especially around how we got started on Blooming Health. As Nima said, my personal background has been in biomedical cancer research and in medical innovations and bringing them to market around drugs, diagnostics, devices. But what led me to this stage and to Blooming Health was the death of my grandmother. When she passed away in 2015, that's when I started thinking a lot more about the aging journey and what it entails. And I realized 80% of the things that influenced her were non-medical. And none of us were quite familiar with what was going on with her, especially in her case, it was social isolation and loneliness. But also in the last 1.5 years, we were caring for my father-in-law with Parkinson's at home in New Jersey, and I was dealing with the realities of life in that regards. So anyways, I'm excited about this conversation because this is around integrating medical and non-medical care, and Michelle has been a key champion in driving that in her career. So I'm really excited for this conversation. And also in talking about Texas, right? I think in Texas right now, this is a very critical moment in terms of the demographic changes that are happening. In urban, there's more growth, and rural areas, there's more disparities, and also the federal policy changes and how they are impacting the local dynamics in terms of healthcare. So I'm excited for this discussion. So I want to kick off with a brief introduction on Michelle. So Michelle Alletto serves as the Chief Program and Services Officer at Health and Human Services Commission in Texas. She has over a decade of experience working in public health and public management. She has held senior roles at Millbank Memorial Fund and Louisiana Department of Health, Association of Maternal and Child Health Programs. And she has a master's degree in public administration from the Syracuse University up New York. So glad to meet you here, Michelle. So to get started, can you please share a little bit about your role at HHSC and the programs and services you oversee?
Sure. Thank you so much for that introduction, Kavitha. That's very kind. Yeah. And I'm also very excited to be here. I know that I have some of my partners in the audience too, some of our contractors with HHSC. I know I think we have a AAA here. Do I have my AAA anywhere? They're on their way. They're at the wrong belly. They'll be here soon. But many of you in this room make up a lot of the work in the spaces that I am also in, and so I appreciate all that you do every day as well. My role at HHSC is really to be a leader for 5 divisions at HHSC. One is our state hospital. I'm going to talk a little bit more about that. Our state hospitals and supported living centers for people with intellectual disabilities. I am over our family health programs, things like WIC and early childhood intervention. We're going to talk about those. And I'm also over our access and eligibility, which is SNAP and TANF and Medicaid eligibility applications, how people enter our front door. We also run our 211 system out of that division. And then I have a cross-disability division as well as a behavioral health division.
That's awesome. Thank you so much. Not too much for one person.
No, it's an easy job.
Awesome. So we are here to talk about breaking the silos. So I'm curious to learn how your partnerships are driving integrated care, and especially in rural communities, how is it driving access to better care?
So I have two examples to share with you, and both are definitely have coverage and are going to have impact in both rural and urban areas. One I think would be of interest to this group and to you, Kavitha, is our work around integrating our maternal and child health programs. We have several programs in our Family Health Services division that are really serving the same families. Families don't look at titles and program divisions and leaders' names. They see services. And a lot of the services that are separately managed in that division are services that families access. And so we're looking at how to better integrate those. Those are things like WIC, early childhood intervention, family violence programs, parenting support programs, and programs for pregnant and parenting moms. And again, same customers for many of those programs. And so we are doing some really interesting mapping work of all those providers. That's actually being done, if you can believe it or not, for the first time. Where do we have a WIC clinic? Where do we have access for family violence survivors? Where do we have access for early childhood intervention? And where don't we? And that is helping us to figure out where we can make additional connections on the ground, which is part of our theme of work today. And one very quick example of how we're doing that, we're also similar to your interest to Blooming Health, is closed referrals between those programs. And so one simple example is in our Thriving Texas Families program, which serves pregnant and parenting moms and fathers. We have a QR code that's new. This is a new thing. And in government, that kind of technology is like earth shattering, right? We've all had QR codes, seems like forever, but for us, it takes time to adapt and adopt technology. So we have a QR code that's on our Thriving Texas Families paperwork and applications, and that is a QR code to a WIC clinic that is close by. And we also will be able to know if that individual who got that WIC referral actually did go and receive WIC services. And if not, we can look into why. And if there were access barriers that we've created, try to eliminate those. So that's one example. And then the other is our Certified Community Health Behavioral Health Clinics, or CCBHCs, which is a national model. It's a SAMHSA approved and endorsed model where individuals go into what would typically be your typical mental health services, but they also, in a certified behavioral health clinic, receive substance use disorder services if needed, as well as some physical health care. We have a lot of people that come in at maybe for a mental health crisis, but have some more immediate physical health needs before we can treat and address the mental health concerns. And so that's a model that will allow for that. We have 41 of those across the state, definitely in urban and rural areas.
Very important. I think I want to clarify, we don't judge any type of technology usage. Technology that works, right? QR code works.
That's right.
That's why we even designed our platform to reach people via landline voice calls and text messages. So internet access shouldn't be a reason why somebody doesn't get access to their benefits or services. So very helpful examples on the maternal health and behavioral health case. I'm also curious how your team and your partners are supporting families during the time of discharge from hospitals, because that's a very fragile time. And even for us, we were all trying to figure out what type of diapers should we get, what type of bed should we get, or how do we support our father-in-law in his transition. So I'm curious, what services or programs are you developing there, especially to connect people once they leave those hospital walls to the supports?
Sure. So we have, and this is what some of the work that we do through our partnerships, we have different services depending on what you're exiting from, whether that's a nursing facility, an inpatient mental health hospital, for example, or you may be transitioning from one of our supported living centers into a more community-based setting. And so for our aging Texans, our aging population, we work with AAAs, and also for disability population, we work with adult with ADRCs, which serve the disability population. Sometimes they're co-located, but that is a partner who really helps families navigate that discharge from a more what we would call closer to an institutional setting, a more restrictive setting into community-based care, whether that ends up being with family and they need family supports in the home, or it is a group home setting. We really rely on those partners because they know the ground. They know the providers, and we know that families in those situations need, as you were just describing, Kavitha, need a lot of support. And while they're worrying about their loved one and making sure they transition to where their preferred placement, they really need the support on managing the bureaucracy. And so that's what our AAAs and our ADRCs do for those families. And then we have the other thing I'll share is we have 4 models right now of step down from inpatient mental health that we are pilots. It's moving from pilot to program, but we have 4 sites. Would love to see it everywhere. Funding is really the restriction there, but the legislature has been very generous in allowing us to set up these 4 programs across the state, and they really allow that transition from an inpatient mental health hospital, particularly for those who had several readmissions. It really focuses on that population and gets those folks into very, very intensive services as they discharge from the hospital. It's really something that starts before discharge in the hospital, and our local mental health authorities are instrumental. How many of you have heard of our local mental health authorities or work with them in your areas? Several. They are definitely our boots on the ground when it comes to mental health, and so they operate these step down programs, and they're the perfect people to do it because they manage some of our inpatient hospital bed availability and also provide the community-based mental health care. So in 4 of those sites, we have this intensive step down program, and it's something that I would love to see in more places.
No, that's very helpful. And I think in our work with the area agencies on aging and senior centers and others, we've seen 90% of the older adults want to age in place in their own homes and in their communities. And that's true with whether you're suffering from mental health or from other conditions. You want to be surrounded by the people you love and you connect with. So appreciate the services, and hopefully the 4 programs become hundreds of programs and scale across the state soon. And I think you started talking a bit about how are we helping moms through the SNAP and the WIC program, but I'm also curious what type of programs and services are being offered to support in that first year of child development, especially as we look at metrics around infant mortality and the criticality of that first year for both the mom and the kid.
Thank you for that. One of the largest, I think, farthest reaching programs that we support at HHSC is home visiting. We support nurse family partnership. Do we have any nurse family partnership providers or home visiting providers in the audience? No. We have run several different models. Nurse family partnership is obviously by its name provided by nurses who go into voluntary program, go into a home. I believe it's up to age 2. Somebody can correct me if I'm wrong on that. And provide coaching, counseling, and focus on care for not only the child and how they should be beginning to access healthcare, and if needed, some developmental, I'm going to talk about that in a minute, resources, but also on mom and what she needs to be successful and healthy herself. And then the other program I would mention is early childhood intervention. We have several of these programs that are co-located, actually, early childhood intervention and home visiting programs, and they work collaboratively. Early childhood intervention, many of you have probably heard of it. It's a federal program that is run through states. And the legislature also provides additional general revenue funding to expand the early childhood intervention program. And this really focuses on children who have some signs of a developmental disability, a developmental delay. And the early childhood interventionists go into the home with the family and provide coaching and hopefully resources and methods to either curb or totally eliminate that developmental delay. The program is really focused on school readiness That's the main goal of the program, but it also operates and functions as a health program, really, when we're going in and looking at those developmental delays and seeing what we can do and what resources, most importantly, what resources we can connect that family to.
Yeah, no, that's very helpful. I've personally seen the impact of such early child intervention programs for some of my families in New Jersey too. And I can see the effectiveness of those when scaled. And I think we're talking about birth to death in this conversation of all different age groups. And I think a critical age group that is important for the future, for all our communities and for ourselves is youth. And unfortunately, there's a rise in demand for youth behavioral health services. Can you talk about how Texas is applying the strategy to support these youth with their behavioral health situations?
Yeah. Absolutely. And like you have your personal story, I have a personal connection to youth that have significant behavioral health needs, and so it's a group that is very close and near and dear to my heart. And it is a population. It's a group of individuals that our systems are not really set up to help. And so we have to do a lot of coordination between multiple agencies and multiple programs to serve youth with complex needs. And when I say complex needs, I'm talking about potentially an intellectual developmental disability, mental health concerns, and many of the individuals that we serve have significant trauma in their lives and in their background. And so we have a continuum of care that we really try to provide. Again, all of this isn't statewide, but we do our best in the places that we can provide it. We just started youth crisis outreach teams, which are teams that are trained specifically for youth de-escalation in the home. And also trained on how to work with the families. If there's an episode of crisis, typically it's a mental health, but again, could be multiple things going on with that individual. And really the goal is to prevent any interaction with the institutional care or additional interaction like juvenile justice, foster care, any of our inpatient services, and really to keep that family intact and keep the child in the home. And it's also a way, it's a bridge to connecting to mental health services and IDD services that maybe they didn't access before. So we also see it as a conduit to more community-based care. We also have a couple of projects that are focused on kids that are either at risk of being relinquished by their family to foster care or in foster care. One is our residential treatment project in our RTC, and that is a pre-relinquishment residential treatment center. RTCs are typically known for having children who have already been through the system and have been relinquished into foster care. But these particular RTCs are designed to give families an opportunity for respite prior to relinquishment. They have incredible outcomes in these programs. Families, I look at it as it's not just the child and youth in these situations that need help, but it's often the family unit. And so we really try to focus on that and provide services. And a lot of those services, again, are through our local mental health authorities. And then we have, lastly, we have a lot of programs for youth, but I don't want to talk too much. But the last thing I'll mention is a new facility that we are standing up in Terrell, Texas. And this is specifically for youth that are in foster care already that have significant needs. Again, histories, tough lives to be so young, trauma in their background, dealing a lot with mental health, possibly developmental issues. And again, there's no one system right now that we have that's a traditional system, not the IDD system, not the mental health system, not juvenile justice, not child protective services, that really can wrap around what these children and their families need. And so this center is really supposed to do that, is supposed to give the children an opportunity either for reunification if that's safe, or an opportunity to go into foster care and have success in that environment, in that setting. So we're excited about that center that will be standing up.
That's awesome. Congratulations, and looking forward to the success of that program. But I think we're coming towards the end of this conversation, but in reflecting on what you've been sharing so far, it's truly about providing the services, meet people where they are in their moments, and especially with different populations that we've discussed, they're in some of their most vulnerable moments in that situation. And that's why we're always in awe of our community partners and service providers and medical providers who are supporting these individuals. We are a technology company. We are focused on enabling care. We don't do the services ourselves. So that's where it's always humbling to work with such partners and the level of dedication they provide in those moments. So appreciate all the information you shared today. I have one last question for you. Based on everything that's out there and what you're working on and what's coming ahead, what is one thing you're most excited about for 2026?
What a good question.
Can also be a call to action for the people in the room.
No. And our Zoom friends, I am most excited about different agencies coming together to serve our youth. I've seen in Texas unprecedented partnership between our Child Protective Services, Juvenile Justice, and Health agency, our agency. And it really, at the end of the day, is about what that child needs. And they may, at different points in their life, interact with any of our systems. But as I started with, families experience is with the state. It doesn't really matter, our lines and divisions don't matter. What matters is that child is getting what they need when they need it. And so I'm excited about that continuing partnership that, again, is, I think, unprecedented in the state. And I commend the leadership of both of those agencies, and my own leadership, Commissioner Muth, for really prioritizing this population and solutions.
It's awesome. Thank you so much for all the valuable information and thoughts you've shared with us. Blooming Health is very excited and committed in supporting the success of those initiatives through our partners. Thank you once again for joining us for this kickoff session. This was a great way to kick off with you. And for this particular session, unfortunately, we don't have a question and answer section, but we encourage you all to track your questions and send them to, I think, Chief Programs and Services Officer at hhs.texas.gov. I got it right. Thank you so much.
Thank you, Kavitha.
Thank you.
And thank you to all of our partners that are probably on Zoom and in the room. Thank you for